Welcome to the peer-to-peer podcast, New Perspectives in Diabetes, New Targets, New Therapies, and a New Approach to Patient Management. This activity is sponsored by the France Foundation and is supported by an educational grant from Bristol Myers Squibb and AstraZeneca. Today's discussion, titled Emerging T2DM Therapies Targeting the Kidney, is presented by Dr. John Gerich and Dr. Stephen Wittlin. Let's listen in.
I'm Dr. John Gerich, Professor Emeritus at the University of Rochester School of Medicine, and my colleague, Dr. Stephen Wittlin, Professor of Medicine at the University of Rochester School of Medicine, are on the line, and we will be discussing emerging therapies of type 2 diabetes with special reference to a new class of agents that inhibit the reabsorption of glucose. We have several learning objectives to formulate a patient management strategy that targets the ABCs, and Dr. Wittlin will discuss these. And then we will look at the rationale for targeting renal glucose transport and talk about some of the individual SGLT2 inhibitors in development. So let me turn the mic over to Dr. Wittlin to discuss what are the ABC targets for people with diabetes.
Well, the ABC targets have been recently revised about a year and a half ago by the European Association for the Study of Diabetes and the American Diabetes Association to individualize therapy with a patient-centered approach. There are now legions of data showing that the lower the hemoglobin A1C, the lower the incidence of microvascular complications of diabetes, to wit, retinopathy, neuropathy, and nephropathy. Furthermore, studies such as the DCCT edict and a recent study performed on patients with latent autoimmune diabetes suggest that the overwhelming proportion of cardiovascular risk reduction in patients with type 1 diabetes or LATA appears to be due to reduction in hemoglobin A1C. So,
now, there were some recent negative trials, but these were secondary intervention trials, right? And people already had severe cardiovascular disease.
These are in type 2 diabetes. And
yes.
in type 2 diabetes, in the ACCORD trial in particular, aggressive control below a hemoglobin A1C of 7% appeared to actually increase the risk of cardiovascular disease and cardiovascular mortality. This appeared on subgroup analysis to be particularly targeting those people who were in poor control to begin with, who were driven down to aggressive targets with hemoglobin A1C. There is a suspicion that that is due to hypoglycemia, and therefore that leads me to the hemoglobin A1C targets, and that is that based on the DCCT in type 1 and the UKPDS and now other trials such as the ADVANCE, it appears that a reasonable target in patients who are at lower risk for cardiovascular disease amongst those with diabetes, a reasonable target is 7% or lower hemoglobin A1C. In those who have pre-existing cardiovascular disease or are particularly at high risk and have comorbidities, such as the elderly, such as patients who may have had a stroke or cardiovascular disease, a reasonable hemoglobin A1C target would be somewhere between 7.5% and 8%, and that's part of the individualization that has now emerged in the treatment targets that have been set by the two major organizations I cited before.
Okay. Now, there have been changes for blood pressure and cholesterol recommendations. Am I correct in that?
Yes. The blood pressure recommendations currently are for systolic less than 130 and diastolic less than 80 as a general rule in patients with diabetes. And interestingly, again, in the ACCORD trial, It appears that further intensifying blood pressure control in a subpopulation of patients actually may increase risk of poor outcomes, and therefore the as low as you can go concept for blood pressure has been put in abeyance, at least for the time being. And if a patient has a blood pressure of 130 or below, that is probably considered adequate at this time.
Okay. Now for the LDL cholesterol, usually it's, if you have diabetes, it's recommended that you get down to about a 70 with statin therapy. But that's, the American Heart Association has come out with a different recommendation.
Yes. The American Heart, well, first of all, the old targets for LDL cholesterol of less than 100 if there are no other risk factors in a patient with diabetes, or less than 70 if the patient has had pre-existing cardiovascular disease or other factors such as angina or hypertension, etc., were really inferences based on studies comparing high and low dose statins. There really were no studies that said, okay, let's target an LDL of 130 versus 100 versus 70 and compare outcomes. So these are inferences. So now the American Heart Association is suggesting that patients with diabetes be treated with high-dose statins. And all diabetics, regardless of the LDL. And I find this interesting because they say diabetics. To my knowledge, there are no studies looking at type 1 diabetics being treated in a similar manner with high versus low dose statins, or versus treated toward a target of 100 versus 70. So there really, any inference that is made vis-a-vis type 1 diabetes is guesswork at this point on our part.
So the American Diabetes Association has not changed their official guidelines.
Right. Their current guidelines would be an LDL cholesterol of less than 100, in men an HDL cholesterol of over 40, in women HDL cholesterol over 50, and triglycerides less than 150 milligrams per deciliter, unless the patient has other risk factors, in which case you would target an LDL cholesterol of less than 70 milligrams per deciliter.
Okay. You know, recent data suggests that a small percentage of patients are actually at all of these goals. I was looking at some study, and it said that something like less than 7% of patients have the desired HbA1c, blood pressure, and cholesterol goal. And if you look at the individual ones, it's all below 50%. So we've got a long way to go there, which brings me to managing the hyperglycemia. Recently, a new class of drug has been approved by the FDA. This drug inhibits the reabsorption of glucose by the kidney via blocking the SGLT2 transporters. Now, that's sodium glucose transporter. Normally, the kidney filters about 180 grams of glucose a day and reabsorbs all of it. These inhibitors can cause as much as 80 grams of glucose to appear in the urine. And there have been clinical trials comparing them to sulfonylureas, DPP-4 inhibitors, and in terms of efficacy, they stack up pretty good against these agents. They also have several added benefits. You get weight loss because you're losing calories in the urine, maybe 2 to 3% body weight, and you also get a reduction in blood pressure, and this can be about 4 millimeters of mercury systolic and about half of that diastolic. Now, on the other hand, these agents tend to raise LDL cholesterol, anywhere from 2 to 6%, and they have as their major side effect an increase in genital tract infections. These are basically candida, vaginitis, and balanitis.
That's primarily there's a higher incidence of these complications in women than men. Is that correct?
Yes, and most of the balanitis occurs in non-circumcised men.
Is there any speculation, Dr. Gerich, as to why only 80 grams as opposed to the full 180 grams of glycosuria occurs from the SGLT2 inhibitors?
Well, it's not known why, but there was a recent article by Dr. DeFranza who outlines, I think, 9 possible reasons why that may occur. And one prominent reason is there might be upregulation of the SGLT1 transporters. 90% of the glucose that's reabsorbed occurs via the SGLT2 transporters and 10% by the SGLT1. So it's possible that there might be upregulation of the SGLT1 to compensate. Now, these agents depend on renal function. Their efficacy is related to the filtered load of glucose. The more that's filtered, the better they are at increasing glycosuria. Now, the filtered load of glucose depends upon the arterial blood glucose concentration and the glomerular filtration rate. So as the glomerular filtration rate decreases, so does the efficacy of these agents. Now, the only agent that's approved in the U.S. at the present time is canagliflozin, and it is not recommended to be used in people with estimated GFRs less than 45 because it's ineffective. Dapagliflozin is approved for use in Europe, and there the restriction is for people with estimated GFRs above 60.
Since these SGLT2 inhibitors are highly specific for SGLT2 as opposed to SGLT1, but since there is some SGLT1 effect, for example, in canagliflozin, which is only 65% absorbed, might there be some gut effect on SGLT1 from these inhibitors?
Well, yes. As a matter of fact, at the high dose of canagliflozin, the 300 milligram dose, studies have shown that you delay gastrointestinal absorption. Not inhibit, but delay. And this has a beneficial effect in lowering postprandial hyperglycemia. And so its effect does not totally depend on the kidney. Now, there's another inhibitor in development, and this has considerably more inhibitory effects on SGLT1 than the other agents. There's not a lot of data out on this, but it does not appear to increase GI side effects. The fear was that if you inhibit SGLT1 to a significant effect, you're going to cause diarrhea or side effects like you get with acarbose.
Are there any increased overall risks for cancer with any of these agents that we know of?
Well, when dapagliflozin was evaluated at the FDA hearing, there was an imbalance for breast and bladder cancer. You do not see any imbalance so far with any of the other drugs that are in development. And my own opinion is there's no mechanism by which these agents could induce breast and bladder cancer because there are no SGLT2 receptors there. So I think this was a failure in randomization. There have been no head-to-head clinical trials with any of these agents. And for the most part, they look reasonably similar in their abilities to lower HbA1c, at least as good as sulfonylureas, maybe better than DPP-4 inhibitors. They look pretty much the same in their side effect profile as well. Well, I think they're going to have a big impact on treatment of diabetes because they do not depend on beta cell function. So they're going to have durability. As beta cell function deteriorates in people, they're not going to lose their effectiveness, and they can be used in combination with any other anti-diabetic agent.
Since they do not require beta cell function for their mechanism of action, is there a potential for use of these drugs as adjuncts in type 1 diabetes?
Well, yes, there have been one or two studies just published in abstract form so far that look in using them along with insulin. No agent has FDA approval for that use, but it is being investigated, and theoretically it should work just fine.
So, Dr. Gerich, as we close the year 2013 out, are there any other SGLT2 inhibitors in the pipeline?
Well, all told, there are at least 9 that are undergoing phase 2 or phase 3 clinical trials or have actually completed them. We have canagliflozin, approved in the U.S., dapagliflozin, approved in Europe and undergoing reevaluation by the FDA. Empagliflozin has been submitted to the FDA, and I think we can expect probably positive results on these 2 agents, and they might be on the market in the second half of next year. Also in development, we have ipragliflozin, tofagliflozin, ertugliflozin, lusigliflozin, LX4211. That agent has appreciably more SGLT1 activity than the others. So there's a lot of activity in this area, and I would expect by the end of 2014, we will have at least 3 agents on the market in the U.S.
This concludes the discussion. We would like to thank Drs. Gerich and Wittlin for their contributions and continued support. Thank you for listening. To receive credit, please complete the evaluation form found on the website www.t2diabetescme.org.